I sincerely wish these services would have been available when my stepson needed them as a teenager. So here's Bradley Grigg.
Hi there, my name is Bradley Grigg, the Chief Behavioral Health Officer at Bartlett Regional Hospital up in Juneau, Alaska. I appreciate the opportunity to speak at the Emergency Medical Services All Grantee Conference this year. And I know that we have another individual, Mark Johnson, who has spoken and shared some thoughts around the pediatric crisis we are experiencing and have experienced in Juneau over the last 18 to 20 months. So I do want to talk about Juneau's response to a growing pediatric behavioral health crisis. So I will leave enough time for questions and comments at the end. So I look forward to those and we'll go from there. So while a lot of people have traveled to Alaska over the years, a lot of people haven't. And so I just wanted to share a brief snapshot of Juneau. Population in 2019 was about 32,000 people. Juneau is the capital city of Alaska. It's the most remote capital city. You cannot get to it by land. You have to get to it by air or sea. There's no road system in or out, about 40 miles of highway that connects us to nowhere. So quite remote. We are one of the cool things about Juneau is we are adjacent to the Juneau ice field that consists of about 1,500 square miles and 30 glaciers. So just a beautiful playground for us to enjoy. We work hard, we play hard. And of course, as you see in bullet 4, zero road access to the rest of Alaska or North America. One of the biggest economic drivers for Juneau historically has been cruise passengers. Up until 2020, we were averaging between 1 and 1.2 million cruise passengers per year coming into Juneau. And I say pre-COVID because that's what we're here to talk about today. One of the things that Bartlett has experienced over the last year and a half is a significant crisis as when it pertains to mental health and substance abuse. So our behavioral health department has had to step up and respond in a lot of ways. But before I get to that, I do want to do a brief introduction to Bartlett Hospital. But just to give you another snapshot based off the demographics I just shared, we are a 72-bed acute care facility. Our services include emergency department, OBGYN, medical, critical care, behavioral health, inpatient and addiction medicine, residential, surgical services, physical rehab, and several other community-based services that we provide. I share this because as we are isolated here, we do things that regional hospitals in other areas of our country simply do not do. We're tasked, and especially with behavioral health, of looking at things from a community perspective and doing things that maybe community behavioral health services where they don't exist, our hospital is asked to step up and provide some of these services. So some of the things that I'll be sharing today are definitely non-traditional when it comes to acute care facilities for medical hospitals. But at the same time, I think it's really cool that a hospital in a town like Juneau has been able to step up in such a crisis and respond in a very big way to a pediatric behavioral health crisis. I kind of want to set the stage and just talk about the adverse childhood experiences, the ACEs study. I'm sure that most everybody on this call has heard, but I don't want to assume most folks are fully aware of ACEs. Alaska has invested a lot of its time in looking at the impact on ACEs, mainly because, unfortunately, we find ourselves ranked highly most years when it comes to the number of children who were exposed to these adverse childhood experiences. If you look on your screen to the left, the big 10 that are listed there that hit neglect, abuse, and dysfunctional households, those are the primary adverse experiences that Kaiser Permanente years ago when they initiated their ACEs study, and that we still do today in Alaska on a statewide and a borough basis. We don't have counties, we have boroughs here. So obviously, without reading the page too much, I did want to offer a bit of an introduction to what ACEs are, and then I want to add some specific Alaska base just to set the stage for how we feel like that the impacts of COVID, while it may not hit household dysfunction, neglect, or abuse, what we are seeing and hearing from patients that are coming into our emergency room in crisis is that these items have more intensified. And therefore, we believe that some of the impacts and the mitigation efforts, while necessary, have resulted in some really adverse experiences for not only young people, but adults. But we're going to focus on the pediatric population today and go there. Just a little specific Alaska experience. 2 out of 3 Alaskan adults have an ACE score of 1 or more. So this was done originally in 2013 by the Department of Health and Social Services, the Division of Behavioral Health. And what we found through this as we looked, I did do the types of ACEs again on the right for you to look at. What we found was that 66% had at least 1 or more adverse childhood experience in their life. So bringing this down to Alaska, more specific, the so what for us, how do ACEs affect the people of Alaska? And again, this is studies and research that's done through the University of Alaska Anchorage, through the Alaska Children's Trust, and through the Department of Health and Social Services, noting that ACEs affect people in Alaska 3 different ways. It's noted that it causes toxic levels of stress, that like unmanageable stress disrupts normal brain development and can lead to lifelong social, emotional, and cognitive impairments. And we'll get to some examples there in a minute where we are seeing for ourselves based off of Kaiser's original study. We are seeing in Alaska, we're seeing the same outcomes, unfortunately, even more intense than what was originally done in the Kaiser study. Number 2, ACEs also strain and weakens children's organ systems, so physiological. And finally, the effects of ACEs may be embedded in a child's DNA. Now, while that is early and potentially controversial in saying, what we are seeing is the ACEs of one parent from their own childhood experience. We are seeing in Alaska the possibility of that being passed on to the next generation, to where that adverse childhood experience is definitely impacting their children and their grandchildren. And as we get into the ACEs, obviously this study really looked at from a perspective of the more ACEs you have, the more impact that has on your life, not only as a child, but as an adult. But in Alaska, over the last 8 years, we've noted that a person with 4 or more ACEs, and remember the four or more ACEs, all of the items that I listed there, an individual is 12 times more likely to attempt suicide, 10 times more likely to use injection drugs, 7 times more likely to be an alcoholic, 3 times more likely to be unable to work, and twice as likely to earn less than $20,000 annually. Twice as likely to be a dropout of high school, and 2 times as likely to have heart disease, stroke, cancer, or diabetes. And one of the things that we have looked at for years in Alaska is because we see the impact that these adverse experiences have. And unfortunately, what we are seeing over the last 20 months with the impact of COVID-19 in our community, our isolated community, is that we are seeing more attempted suicides. We are seeing increased substance use in terms of drugs and alcohol. We are seeing people lose their jobs. We are seeing people quit not only high school, but college. And of course, obviously, with folks who already have struggles in their life in terms of health, we're seeing increases in some of the physiological challenges that they have. Okay, so I want to share our capacity that we had prior to COVID, and we're gonna say that as March 2020, because when you look at some of the data I'm going to share later, that's where we really started tracking the significant surge that we saw in terms of patients coming to our ER in crisis. So I joined Bartlett in July of 2017. At the time, this was the behavioral health services we had, and while it's actually really good that we had these services, I think what you find here is not a lot of focus on children and pediatric family care. We had an adult inpatient psychiatric unit with a capacity of 12, an adult residential addiction center, capacity of 16, an adult withdrawal management detox center with a capacity of 4. And after all that, we do have a child focused program that was both child and adults, an outpatient behavioral health physicians clinic. And at the time, we had a capacity to serve up to about 150 comfortably. So what that really meant for us is if a pediatric patient came into our emergency department, into our system, experiencing a psychiatric crisis, because we have no acute care services here in our community and no access to a road system, families were often faced with putting their child on a plane to go to either Anchorage or Seattle for acute care treatment. And in many cases, given the financial situation and the insurance coverage of our patients, while the family may have been able to go up with the child to get them settled if it was Anchorage, or down if it was Seattle. And to give you a little bit of background, Seattle is about 900 air miles from Juneau nonstop, and Anchorage is about 600 air miles from Juneau nonstop. So 1.5 hours north or 2 hours south is where this child would have to go for acute care psychiatric services. Not optimal for families with limited resources, or even families with resources. Not optimal for a family to stay connected with their child when they're experiencing psychiatric crisis. So this has been a long-term goal of the board even before I joined the hospital in 2017, but we have gained a lot of traction, and I will be excited to share with you shortly what we are doing to address this need even now. So I want to focus on the next few slides mainly on COVID's impact in Juneau. I think some of the terms that I've used when we've had press conferences and media inquiries is we have experienced since March 2020 an unrelenting wave of pediatric patients that we have never seen come into our system experiencing a psychiatric crisis, to the point that we have really had to pivot what we do to meet the need. Not having access to a road system, not having access to acute care services, we quickly found ourselves experiencing such an increase in young people coming into our system that my medical director, myself, and our team had to pivot in such a way to try to catch up to this wave that was hitting us. You know, in March of 2020, in our region of the country, Seattle was experiencing a major surge in the nursing home populations. And of course, us being just north of them, we were preparing ourselves for any surge that may hit us. And what we found in the first couple months of COVID hitting Juneau in Alaska was our wave, and our surge was actually behavioral health crises. So this first chart I want to share, and I'll share a little bit of the details so you don't get lost in the numbers, but I feel like it's important to talk about this in two different ways. I want to go at this from looking at July of 2019 through March 2020. Basically, that is the academic 2019-2020 school year, where things were what we used to call normal. And leading up to March 2020, which was our spring break, and in Alaska, our governor set out an executive order that after spring break, that schools would finish the year out on a virtual basis. So that's kind of the ending point where we look at this. So I'm going to look at those first 3 quarters of fiscal year 20, which is July 19 through March 20. And then I'm going to look at FY20 quarter 4 and FY21 quarter 1, so that you can see the impact that we saw based off patient presenting into the ER and in their self-report, that we have no doubt that the wave we saw was specifically tied to COVID, the mitigation efforts that, while they were the right thing to do, a side impact of that was this increase in services needed for pediatric patients. So this data is all pediatric. A little bit of context. From July 19 to March 2020, we weren't seeing a lot of kids in the ED. That's a good thing for us. We have a strong, historically adult system where we have a psychiatric emergency services system that can assess a patient who's in crisis within our ER setting. And through those first 9 months, we saw 6 total youth that were 13 and under, and 33 that were age 14 to 17. If you look at right under the graph. So in essence, in those 9 months, between the ages of 13 and 17, we saw 39 youth with a monthly average of about 5, with that average of age 13 and younger once a month, age 14 to 17 for a month. As you look at April to June, and I do want to reiterate, this is when schools went virtual. This was when everything started to lock down. Mitigation efforts were at their peak at the time. Parents were having to step away from their job and work remotely or lose their job. We're a heavy tourist company, and as you go into March and April, we're preparing for our first cruise ship, which is typically the 2nd or 3rd week of April. And all of a sudden, we're faced with a shutdown of not only our economy, but our systems, from education to our state government, being the state capital, our state government has a big footprint here. And all of a sudden we're faced with all of these changes, and immediately following school going virtual after spring break in March of 2020. Take a look at April 20th through June 20th, both for the ages 13 and younger and 14 and 17. You'll notice that the previous 3 quarters for 13 and younger, we saw 6 total pediatric patients. In the very next quarter, we saw 22 in 3 months alone. So we went from averaging 1 a month to 7 a month. In the same time frame, the age 14 to 17, we doubled. We went from averaging 4 a month to 9 a month. And that went even higher when you look at July through September. The rest through summer and the start of the next school year, which in Alaska, in Juneau, families did have the option of doing virtual or homeschool. We did. There were some communities that did some in-person, but for the most part, our 2020-2021 year was a virtual or a homeschool option for families. We did not have in-person teaching for any significant length of time due to positives happening throughout our community and mitigation efforts saying that we should keep our children home for virtual education or for homeschooling. So when you look at the July through September, we've gone the previous 9 months of averaging 6, 13 and under to now, between July and September, we're averaging 10 youth a month. So we've enhanced our average from July of 19 to September of 20 on a quarterly basis. Our monthly average went up 10 times. And when it comes to our age 14 to 17, our monthly average of seeing patients coming into the ER in behavioral health crisis went from 4 to 14. So almost 4 times the amount in just a short period of time. That's a short period of time to experience something of that level. And while the numbers on the surface don't seem a lot, when you have a capacity that has historically averaged 1 a month or 3 or 4 a month of these age groups, and all of a sudden you see in just a few months' time, that goes from 4 times to 10 times the amount of patients we're seeing, in addition to the adults we're seeing. We found ourselves in quite the crisis. I've often used the term unrelenting. And when you look at this data in the next couple of sheets I'm going to be sharing, it truly has been an unrelenting 18 to 20 months for Juneau. I will say a majority of the children and adults who were assessed in that first quarter after we shut down from April through June, they expressed this was their first time ever even experiencing a behavioral health crisis. We were in a small town like ours, obviously. You know people, you know them from the grocery store, you know them from the businesses you go into, you know them as your neighbors, your coworkers. In our world, in behavioral health, you know your patients who come in often and frequently in need of supports. What we found in that first month was an unusual amount of patients that had never crossed into our system who were experiencing crisis for the first time. And while we were grateful that they were showing up for our supports, what we found really quickly is we were not prepared to meet the need that was hitting our door. So again, I'll be really grateful to share with you what we have done since this March 2020 shift. But before that, I do want to also communicate. A lot of this was self-report in terms of stressors that were communicated by youth when they came into the ED, experiencing depression, anxiety, thoughts of self-harm, all of those key points that we look at in our world in terms of ensuring that a patient is within a safe space in order to operate. The stressors that were communicated by youth during this time was their isolation from the social support networks, the lack of sports in our community, as far as youth and community-based sports, struggles with the school year. In that final quarter of school and then the following school year, the Juneau School District had a situation where they were faced with something they had never faced before. Almost half of the students in our school district were failing at least one class during that virtual year. It was a tough transition, and I know other states and communities have had similar to that, but this impact for us was just significant, and we feel like was a big contributor to the growing psychiatric emergency department visits that we saw. So another piece is our outpatient services. I mentioned earlier that we had a capacity before all of COVID came to light for us. We had a capacity of about 150 outpatient slots in our mental health physicians clinic. As you look at this, and while I did include the adult factor here because this slide has been updated and worked on, and shared in multiple avenues. I will just skip down to the children's portion. Our outpatient, again, I'm doing off the same data, the first 9 months of that school year, and that's March 2020 being that spring break where we go virtual, and then we look at the next 2 quarters. In 9 months, ages for children 17 and under, from July 19 to March 2020, we were averaging about 4.1, about 4 new patients a month in our outpatient clinic. So we saw 37 in that 9 months that were new. That's doable. In the very next quarter, from April to June, that 3-month period alone, we had 38 new young people coming into our clinic for services. So we increased by 3 times in just 90 days. And when you look at July through September, we increased even more again, to the point that from that previous 9 months until the July through September quarter, fiscal year 21, quarter 1, we had increased our referrals of just pediatric outpatient psychiatric intakes by nearly 4 times. And so this put us in a situation where we had to pivot pretty quickly. Crisis doesn't merit a wait list, and crisis is immediate. And so one of the things that we did, as you'll see later, is we stood up a psychiatric crisis intervention services program that responded to this, because one of the things, as you know, at this point, I've already stated, we didn't have an inpatient acute care program. So we have these new folks that are coming in that we had never seen, from going to averaging 4 a month new intakes to where we're averaging almost 16 a month. The unrelenting wave hit us hard and hit our community really hard. So again, looking at the same data points, July through March 2020, and then April through September. This is the most telling data for us, because it's the actions that took place, and it's what we saw walking into our ER that really pivoted us and begged of us to respond in a way that met this need. In the 9 months leading up to that March 2020 spring break, you'll see the number of suicide attempts that we saw for age 13 and under and 14 to 17. In that 9 months, those 3 quarters total, we saw 3 suicide attempts come through our emergency department. That's 3 too many. But when you look at the next 6 months, April through September of 2020, as we were going straight into COVID, post spring break, going into virtual education, mitigation efforts, community shutting down on many levels, we went from 9 months of having 3 total attempts to 6 months of having 12. Such a significant increase. And when you look at the 13 and under, to go from 1 in 9 months to 7 in 6 months, we had a crisis on our hands. 2021 has brought more of the same to us. Through the first 6 months, our pediatric emergency department visits are on average about 26 a month. Almost every day we see a kid now. If you remember, prior to COVID, we were seeing an average of 1 a week. We're now seeing 1 a day. Total pediatric suicide attempts for the first 6 months of the calendar year was 16. Unfortunately, 1 was what we deemed successful. And the referrals for outpatient psychiatric care continue to be at a high rate. In these 6 months alone, we had over 125 new referrals for our outpatient services. In 4 years, our outpatient program has gone from serving 35 combined youth and adults to today, we're serving over 750 in just outpatient services. Of those 750, 400 of them, or 500 of them, I'm sorry, have come to us since March of 2020. The wave we've experienced in terms of folks needing every bit of support they can, even if it's just an outpatient basis for psychiatric care and for counseling services, is to the point where we went so high, so fast in need. And as you can see, over the last 6 months, people have asked me many times, well, when do you think this is going to plateau? That's been the common question I've been asked. When do you think this is going to plateau? And my response is, often as I can say it, is I'll let you know when it does, because we haven't plateaued yet. While I can give you averages, This is something that we hope is not our new norm. So some good news after that sombering information. This is where I really am excited to be able to share with you what we as a hospital and our board has done to accomplish responding to the COVID crisis that we had. Our capacity expansion since COVID has merited a lot of new things that has really been what I feel like in a town like ours has been an amazing response to the needs that we were seeing walk through our doors. The expansion of our adult and adolescent, our child and adult outpatient behavioral health physicians clinic now has a capacity of 750. If you remember pre-COVID, we were at 150. It's not something that I'm bragging about, but it's something I'm grateful that we've developed the capacity to meet that need because our community has definitely needed it. In addition to that, and I think this is really big for this platform, is we have integrated a 0.6 FTE, 24-hour a week, board certified pediatrician that works in our physician's mental health clinic to serve those youth who do not have an identified primary care physician. We identified before we started recruiting for this position that we had about 75 youth who did not have a primary care physician. And so if we're going to meet their mental health needs, we want to be integrated in what we do. And if there are complexities and their medical and behavioral health needs are to the point that it's very difficult for families to get patients to multiple appointments, we wanted to make it a one-stop shop in terms of some primary care mixed with and integrated carefully with psychiatric services. And what we've seen in the last 6 weeks since we identified that position and hired and got her set up, we have seen such an amazing response by not only the youth, but the parents who were able to come in to their psychiatric appointment for their youth, but also see a pediatrician immediately before or after, so that it is definitely a team approach by two physicians. Our expansion of outpatient substance use disorder and misuse services to youth and adults has grown. We didn't have an outpatient substance use program prior to COVID, but we saw such an increase in the number of youth that were using substances for the first time or were abusing it to the point of almost dependence, or were at full-blown dependence of a substance or substances. We noted that since March of 2020, almost half of the young people that come in for a behavioral health crisis have been, in fact, misusing substances. And so we expanded to stand up an outpatient program to serve these. A lot of this was telehealth. The first two bullets that I noted, the outpatient physicians clinic and the outpatient substance use services, because of the mitigation efforts we had in place, we expanded our services to be a telehealth option under emergency regs. Gratefully, our state and of course with the support of CMS allowed us to do that. And those services still stand today now that we're back in seeing patients in a hybrid model of face-to-face and telehealth. We created 38 new permanent full-time behavioral health positions through this time since March of 2020. This ranges from psychiatric providers, nurse practitioners, mental health clinicians, behavioral health technicians. In our emergency department now, we now have 24 hours, 7 days a week. We have a behavioral health clinician and a behavioral health technician that immediately following triage, the behavioral health services begin, whether it's a child or an adult. So there are two behavioral health staff who are on our emergency department multidisciplinary team 24/7. And we have really seen a lot of strong outcomes in terms of engagement and helping folks be able to get treatment from the moment they walk in the door with behavioral health focused staff. The fourth bullet, we initiated and stood up a crisis intervention services team. If you remember, I noted earlier on, we do not have acute care in our community, but at the same time, we truly felt like if we could establish a mobile crisis outreach and an in-home community support system in our community, we could lower the number of youth that are going to Anchorage and Seattle for out-of-town care. So what we did is we stood up a team of 7, 2 mental health clinicians and 5 youth and family navigators who, when a youth comes into the ER and is assessed for a behavioral health crisis, whether it be anxiety, depression, thoughts of self-harm, actual self-harm, if for any reason we determine that this patient does not need acute care, we immediately hand them off or offer them a handoff to our crisis intervention services team. This team of 7 works 7 days a week so that if the families came in on a Friday or a Saturday, they don't have to wait until Monday to be seen. We started this program in February of 2021. And since that time, we have actually been in the homes of over 40 families who have been open to us to come in and say, you know what, we acknowledge that the crisis hasn't ended, though we didn't admit your child. We know the crisis is still going on. We'd like to come into your home. We'd like to respond with clinical services and some rehab supports that will help get you through this crisis and figure out an ongoing plan for outpatient services through primary care or through our clinic or through another clinic in town. And we have really seen a lot of support come through this. We've seen great outcomes. We've been able to divert families from having to send their kids 900 miles south or 600 miles north to where they can stay focused with their primary care here in town and develop that psychiatric relationship that they need, in addition to just mainly staying at home and being with family. We did expand our 24/7 psychiatric emergency services located within our emergency department. I spoke to that previously, where we have a behavioral health clinician and a behavioral health technician on 24 hours a day in the ER as part of that team. Because of the complexity of what we do, while it's not particularly connected with COVID, it is worth mentioning that we have, as of July 1, we opened a pediatric applied behavioral analysis clinic to primarily focus on those intense services in the home, in the community, and at school for those children who have the primary diagnosis on the autism spectrum. So that has opened and is in business. And the highlight of where we are as a hospital is we are in the process, after all of that, is we have broken ground. We broke ground 4 months ago on a 16,000 square foot behavioral health hub that will house our outpatient clinic, that will continue to provide 24/7 psychiatric urgent care services, and will now provide a pediatric crisis stabilization unit to where if the patient does need to be removed from the home for crisis stabilization, they will not have to go to Anchorage or Seattle anymore. We will have an 8-bed unit that will be able to serve them, and our estimated completion date is 2022. It's funny, you see a rendering of the actual program above. The bottom floor was going to be our outpatient services, and the second floor you see was going to be our crisis stabilization unit. We have grown so much in the last year that just before construction began, our board and the city and borough of Juneau approved an additional outpatient floor to be built to this hub. So it is now a 3-story psychiatric hub that will provide these full array of services to youth. And I think the biggest piece that we're looking forward to is being able to tell families, you're in crisis, your child needs to be stabilized. And now we don't have to talk Anchorage or Seattle. We can sit here and say, look across the way or upstairs. If they come into the urgent care, the psychiatric urgent care facility, we will be able to serve them from that point forward as a single point of entry to provide that stabilization in Juneau, to discharge them back home, and to have those crisis intervention supports to go back with them into the home and to help that family be successful. So I'm really excited about that. It's one of those things that COVID put us in a position to either fold or respond. And I think it goes without saying, I'm pretty proud of what our team has done. Bartlett has 700 employees, almost 150 are within the behavioral health department. So we have a significant footprint on our campus and in our community. And these 7 bullets alone show that we have responded to the crisis that our kids and our families have experienced since March of 2020. So just a couple of items that I want to provide links to. The work that we've done has gained attention both on the local and state level, but also on the national level. Our surge was not the number of COVID patients in the first year of COVID. Our surge was the number of behavioral health patients due to the impacts of COVID on their lives. These articles are raw, they're real, but they tell a story that really is able to show the crisis that we faced as a community and what we've done as a community to step in and to help our families and to come up with solutions that would be home and community based, locally provided, to where we didn't no longer have to consider 900 miles or 600 miles away just to get the kids an essential integrated service that they would need to get through this crisis and to help them sustain moving forward. So I want to thank you for the opportunity to share this today. It's something that I'm proud to talk about. I have an amazing team of psychiatric providers, clinicians, nursing staff, behavioral health aides, technicians, administrative staff. And with all of them, we're able to do an amazing job. Many hands make light work, but in this case, many hands do amazing work. So I want to thank you for your time. And with that, that is my contact information at the bottom to your right. And I am open to any questions or comments you may have.
Okay, so we have a couple minutes for questions. If anyone has any questions for Mark or Bradley.
This is Mark. I'll just add that I'm very pleased that Bradley was able to finally get us moving in the right direction in our hospital after all the years of spinning our wheels and struggling. So it's very gratifying. And I don't know if it's a model that other places might want to look at, but so far so good as far as I'm concerned here.
So Amy Eisenhower had asked, especially integrating the pediatrician was a great idea. Have you included EMS in your ED work?
Sure, I can respond to that, Mark. And EMS is really our best friend. In a lot of these cases, they are bringing in more than half of the young people that we see, and the adults for that matter. We do have a lot of families who bring their own kids in, but we have an EMS program and a law enforcement program in town who's very responsive and receptive and very sensitive to the needs of patients with behavioral health crises. So they are our close friend, and we work hand in hand with these patients for sure. Not only during the time of transporting them, but after the fact, to where we are even in the process now of ensuring that we have some type of moving forward, some type of triage system in place to where as we open this new facility, we will be able to direct EMS either to the regular emergency department or the psychiatric urgent care, depending on the needs. So grateful for our EMS for sure.
Okay, and Tamara Blakewell asked she'd like to know more about the ABA piece of the program and how it's going. Are families receptive and seeing results in the intervention?
So that is our newest program. I appreciate someone asking that, because while it did not impact, it was not a direct implication from COVID. It was a growing need that we were seeing within our own psychiatric clinic. We identified about 6 months ago over 50 young people who met the criteria for applied behavior analysis. We did have an outpatient clinic in town providing it, but when we got word that they were going to be shutting down, we quickly launched a team to stand that up. And so we have one board certified behavioral analyst. We have a second one coming online in a few months, and we have 5 ABA technicians who are serving. At this point, we have 47 who've been referred to us by pediatric providers. We have, of those 47, we have 32 who have done intakes and who have had services begin. And that's been a really big push, because while it seems like, well, you've got 7 or 8 staff, you've got 43, why aren't you been able to serve them all? The challenge there is the intensity of services some of these kids need. Alaska has really supported that when one child or one family needs even 30 hours a week of intense care, whether it be in the home, the community, or the school combined, we're able to attach someone to them on that one-to-one with the family and with the child. If they're siblings who are in the ABA program, we have 2 staff with them so that they receive that one-to-one care. And we're seeing, even since July 1, we've only been open a couple months, we're already seeing a lot of stabilization, improved behaviors in the community and in the school, to where these young people are actually being able to maintain in their school setting, which is one of our big goals. So I appreciate someone asking about that.
All right, I think that's all the questions we have in the box. Thank you so much for the presentation, Bradley and Mark. And I think we listed the contact information on the screen.
Thank you very
Mark,
much.
for your wonderful work and for coming today and answering questions. Everybody, our next event, I believe, is a plenary session on, is it here? It's here. A plenary session on pre-hospital pediatric readiness. I'm going to post a link here in the chat that should take you back to the GlobalCast main page, which is where you can rejoin the conference. Thank you everyone for coming today, and we'll see you soon in the next plenary. Thank you.